We're very fortunate to have Kate Tulenko, who's an old friend of this area workforce, and as well as personally a friend. We work together a lot. I was reflecting, we first met doing pediatrics, something neither of us are doing much of these days. You're doing more at home. I have grandkids I can weigh in on. But Kate was in a residency at Children's when I was working as a attending at the Upper Cardozo Health Center of Unity. So I can't remember if we shared patients. We certainly shared some gossip and chit-chat and got to know each other. But Kate is a pediatrician by training. She's a graduate of Hopkins, got an MD and an MPH, then went to Oxford and got a DPhil in
History and Philosophy of Science.
History and Philosophy of Science. So getting a DPhil from Oxford is pretty impressive, whatever it's in. And meanwhile, she was a grunt pediatrician at Upper Cardozo. I thought that was terrific. But she's gone on and she spent a time at the World Bank, and now has been in IntraHealth for a number of years, first with a capacity project, and then with, it was Capacity Plus, then was Capacity Project, then Capacity Plus, and has worked on a number of issues having to do with workforce. She also has a terrific book, which has probably not gotten the attention. It's called Insourced, How Importing Jobs Impacts Healthcare Here and Abroad. Kate has played a leading role at IntraHealth in the workforce development area, as well as consulting and doing many other activities in this field. So we're delighted to have her here to tell us a bit about her work and her perspective going forward.
So I'll be talking about Capacity Plus results and lessons learned. And for those of you who aren't familiar with it, Capacity Plus was USAID's Global Health Workforce Project. It was a 6-year project funded at $60 million, so about $10 million a year. And was bureau-wide in USAID, which means multiple sort of verticals put money into it, whether it was family planning, AIDS, maternal and child health, because that's one of the challenges with donors is funding tends to be disease-specific, which in a health systems world is really quite a challenge. And the work was led by IntraHealth International with a number of partners, including Liverpool, APT, LATH, TRG. And we really tried to
say a word about IntraHealth for those of us less
Sure.
familiar.
So IntraHealth.
Go easy on all the names and acronyms.
Yeah, a lot of acronyms, a lot of 3-letter acronyms. IntraHealth is a global non-governmental organization that's been around for 35 years, and we're an NGO in cooperation with the World Health Organization, meaning that we have official relationship with WHO as recognition of our leadership in health workforce. And every year we have a work plan with WHO on health workforce and supporting them in health workforce. And IntraHealth is headquartered in Chapel Hill, North Carolina. I head up our DC office. Then we have about 20 offices worldwide in Latin America, Asia, and Africa. And our specialties really are health systems and health workforce, as well as family planning. And in Capacity Plus, we really tried to be leaders in innovation and cost effectiveness, because we feel that getting access to health workers is really the key thing to focus on. I'll go quickly over many of these so we can focus on the results. The goal was to build country capacity, and I was talking to Fitz before we got started about sort of the challenges of sustainability. There's a saying: if you want to go far, if you want to, go fast, go alone. If you want to go far, go together. And so there's almost a tension between sustainability and getting results quickly for your donor, and trying to manage the two of those. Our goal was also to contribute towards these U.S. government vertical programs, such as an AIDS-free generation, ending preventable child and maternal death, and family planning 2020. So once again, a health systems project serving disease verticals, which is always a challenge because, there's no such thing as an AIDS nurse or a malaria physician, that you have to train the base, the base health workers, and then they go and work in different types of programs. So Capacity Plus truly was a global project. We worked in Latin America, Africa, and Asia, but certainly Africa was the focus. And as far as the technical focus areas, we worked in leadership, country health workforce management, leadership, information systems and data use, education, retention, productivity, absenteeism. I think that group there is one of the sort of the overlooked areas of health workforce.
Come back to that.
Yeah. Professionalization of under-recognized cadres, trying to get beyond the doctor-nurse model, and overarching issues of gender equality, which USAID has just been a fantastic champion of gender equality, both within the workforce and also how health workers treat their patients. monitoring, evaluation, knowledge sharing, and integration of faith-based organizations. And go over this quickly. Some of the things we did in leadership, helping to sponsor both the second and the third Global Forum of Health Workforce. And you might be aware, next November, they're having the fourth one in where is it? Dublin, in Dublin. So that'll be November 2018. And apparently the next couple months, they're going to be putting out requests for abstracts for that.
And who is the sponsoring?
218 and 217.
I'm sorry, 17. I'm sorry, 17. Yeah, 17. It'll be the government of Ireland and WHO are sponsoring it. Yeah. So David Week-Liam, who has been on the board of GWA for a while, is sponsoring that.
GWA is not in the picture?
GWA has sunsetted. It's now GWIN, the Global Workforce Network. But they haven't gotten any funding yet. So, in fact, we tried to put work with GWIN into our work plan with WHO, but they wouldn't let us because there's no funding yet. So we'll see. The space is to be watched. Also worked on consensus building. And one thing we did that is also one of my lessons learned is worked with African parliamentarians. I had done a little bit of work with parliamentarians in the World Bank, and actually they're perfect for health workforce, because when you deal with the Ministry of Health, you're essentially dealing with the center, which may or may not care about the periphery. And most people who work in the center are from the center. They're from the capital city. But parliamentarians, by definition, especially in Africa, which is a rural continent, represent rural people. And they care not only about the health of the people, they care about the economies of their communities. And when you tell them, look, 50% of physician and nursing positions in your community are empty. And if we fill them, you would get that income circulating in your communities. You would also get the improved health in your communities. Parliamentarians pay attention, and parliamentarians in general have power over the purse. So they're really a fantastic group to target on health workforce issues, and a very, in my opinion, very overlooked group. We also ran the HRH Global Resource Center, which is still ongoing. InterHealth has taken it up, and this is the largest collection of health workforce materials in the world, as well as an online community around health work. As part of our initiative for sustainability, whenever we did something, we tried to document it and turn it into a tool, because often projects do incredible analysis, incredible work, but then no one knows how they did it. No one can repeat it in their country or community. And so we tried to turn a lot of what we did into very easy to use tools. And so one of the most successful ones we did is called the bottlenecks and best buys approach. When you're looking at scaling up health workforce schools, deans will give you this laundry list of $100 million worth of improvements that they need. And this bottlenecks and best buys process leads the dean and his or her team through an approach where first they set a goal, like the goal might be increasing the class intake size, or the goal might be increasing graduation rates, or increasing pass rates, or adding a midwifery program to a nursing school. And so once they have the goal in mind, they're then led through a process to decide the minimum inputs to make that goal happen. So rather than sort of the big white elephants and that type of thing, what are the minimum inputs to make their goals happen? We also continue to support and expand IRIS, which is open source, which means free and unlocked software program to manage health workers. I'll have another slide on this, but now 25 countries use this to manage over 1.2 million health workers, and we have literally saved countries hundreds of millions of dollars in proprietary fees. Like if they were to use proprietary software, they would have to pay for it, which is quite expensive and out of the reach of many countries and out of the reach of sustainability. We developed an HRM assessment toolkit, which at a national level or state level can look at what the human resource management is and what improvements can be made. A rapid retention survey. If there are any economists here, this is a discrete choice analysis, which is a very systematic way of finding out what will retain people in a given position. And it used to be that with standard procedures, you would need a PhD level economist and usually $200,000 to $300,000 to do this type of analysis. And we were able to develop sort of a rapid rural approach where you didn't necessarily need a senior economist. You could probably do it for $50,000 to $100,000. And we helped countries actually develop retention plans. Because what had been happening in the past is people in the ministry would just kind of sit there and say, well, when I was a young medical student, 20 years ago, I would have liked a car, I would have liked this or that. So you ended up with retention programs which were neither relevant nor sustainable. But this tool, accompanied with a costing tool, helped design both sustainable and effective retention programs. And also developed an HRA effort index, which helps compare across countries how much they're investing in health workforce and really trying to make the health workforce work. And sort of as a, to sort of put a scoreboard to say, well, Ethiopia is doing better than you are, Nigeria, and creating some friendly competition amongst countries as far as who's investing in health workforce. In management and leadership, we did a lot of work in the Dominican Republic. And one thing I'm sure all of you know about health workforce is for a problem in a country, there's rarely one intervention that's going to help. You often need interventions across a number of areas. I have a slide later on the Dominican Republic, but we helped them create a law, a new evaluation system, helped reschedule work times for health workers. So you have to do this multiple levels of interventions. And in Uganda, we helped do leadership and management development at the district level and actually helped facilities increase the number of patients and decrease stockouts, that type of thing, just sort of basic leadership and management. This is the Dominican Republic slide. So we helped across multiple different areas, helped them with a strategic plan, actually writing law and policy, job descriptions. It's really amazing the number of countries don't have job descriptions or don't have updated job descriptions for public employees. And one of our great accomplishments was helping them identify ghost workers. These were either people that didn't exist and money just went into bank account of someone else, or people who were registered as having 3 or 4 full-time jobs, that type of thing. The government was brave enough to remove these people from the rolls and actually be public about it, and actually have saved over $9 million a year in lost salaries that they're now reinvesting in hiring more real health workers and increasing the salaries of existing health workers. And with this one program, Capacity Plus paid for itself because the budget of Capacity Plus was about $10 million a year. And I'm not aware of any other USAID project that actually has ever been able to say quite clearly that it pays for itself. And so this was quite remarkable. And one of the lessons learned really is that you have to talk about sort of the elephants in the room. You have to be willing to talk about the things no one wants to talk about, like corruption or ghost workers. When David Evans was at WHO, he estimated that about 45% of all MOH budgets are health workforce or health workforce salaries. And it's widely thought that in developing countries, about 30% of health workers are ghost workers. So, this is a significant chunk of your ministry budget that's going into ghost workers. And I firmly believe if this issue is not addressed at the country level, you're really never going to have universal health coverage. You're never going to have the type of care that you want for people, especially people in poor and rural areas where you tend to have more ghost workers. But just another example of the management improvements we were able to make in Dominican Republic by changing the opening times of some of the clinics. We're able to have a five-fold, 500% increase in patient consultations. Many of the patients these particular clinics were seeing were women who worked, and so they couldn't come in 9 to 5. And so by having just a few evening hours and weekend hours, they were able to really dramatically increase the number of women that they saw. Kind of a no-brainer, but sometimes you need outside advice to come up with these things. Data for decision making. I'd mentioned Iris. This is the free HR software. We've already saved countries over $475 million compared to commercial software. So if you extend this over the next 5 years, it will be close to $1 billion that we've saved. So once again, I'm not aware of any other USAID project that has had cost savings on this magnitude. It's a really quite effective and quite a good investment with a good rate of return. One of the real challenges with any type of data is getting countries to act on the data. And one thing that was very helpful with Iris is you could visualize the data. I'll be showing a slide later of Uganda where you can see which counties have empty positions versus which don't have as many empty positions. And we found that policy leaders, once they saw that graphically, they were sort of more willing to make decisions than if you just handed them a table full of numbers. But also we did a fair amount of training in helping policymakers look at data and make decisions based on data. This is just a map of countries that were using IRIS, a partial map. They're now, as I said, 25 countries using IRIS. But what's interesting about this is you'll see that there are other donors who are now funding IRIS. That's what the different colors of the countries are. So World Bank, French aid, the Canadians, the Koreans have all funded countries to use IRIS, and it's become a global public good. In fact, most likely in the next month or two, USAID is going to declare it a global public good, along with DHIS2 and OpenMRS, both of which are open software that's used in health systems. Okay. Another country highlight, Jharkhand used IRIS, and once again being able to map where the health workers are, know graphically and where they were able to reassign OBGYNs. All the OBGYNs were clustered in one area. And you know, demand for healthcare is unlimited, so they were busy in these metropolitan areas, but then there were entire counties that had no OBGYNs whatsoever, so women who needed emergency obstetric surgery weren't able to get it or had to be transported, and huge costs and health risks associated with that. So they reassigned these OBGYNs, hired some new ones, and the actually, you know, governments are rarely willing to sign off on things, but actually the government signed on saying that 900,000 additional people have been covered with health care due to these reassignments. And, you know, to be able to say 1 million people, close to 1 million people now have health care due to these reassignments is really quite powerful. But you'll see, you know, a 740% increase in antenatal care visits, increased 20 times in cesarean sections, really quite, and these were, it was, looked at to make sure that these were cesarean sections that were actually needed rather than elective C-sections. Okay.
Did they save any lives because of that?
We weren't looking that deeply in the analysis. Actually, one of the huge challenges we have with all donors is how much money they're willing to put in M&E. So there's your programmatic money to make the change, and then your M&E money to measure the change, and kind of the balance between the two, and how deeply do you go. And you know, in much of our work, we would just, in some of the work we operated under the assumption that increasing number of health workers improved health, and some we would actually try to measure increase in service. But then you're right, going one step forward is actually measuring increase in health, because getting service does not necessarily lead to improved health. But yeah, that's a whole debate that there is in the M&E community, is how far down do you measure given how expensive it is. Yeah.
Some of the outcomes are clear what the benefits are, and others,
Yep.
and if you can talk about lives saved, I
Yep.
think that
Yeah.
would be pretty
Yeah, certainly USAID is encouraging its NGO contractors to use the Live Save tool more. But once again, a lot of that is just conjecture, and it's based on assumptions. Yeah, absolutely. And of course, the quality of care. All this depends on the quality of care as well.
Are these the project that you were just talking about? Was that something that you said, hey, you might want to do this, or is this something that they took on their own? And what was your role in helping them to figure out about the OBGYNs and their?
Oh, that's something that we advise them. Yeah. For pre-service education, we worked with over 50 schools in 12 African American countries, and contributed to the training of 9,000 new health workers. You might know that PEPFAR was counting health workers, to get to the goal of 140,000 health workers that they had contributed to the training of, and really worked to build schools' capacity to both train more health workers and train more high-quality health workers. This is a map of just some of the countries where we worked, and the investments we helped the schools made. Costing studies, there was very little information on how much it costs to run a nursing or medical school, and what were sort of the cost elements. Very interestingly, in most schools, the number one cost was salaries. When you're starting a new school, real estate becomes a large cost as well, but still it's the salaries that a major driver of costs in health professional schools, which in the digital age of flipping the classroom and having taped classes and the possibility of that, there really are quite some cost savings that can be achieved in health professional schools.
What kind of graduates were they putting out?
We were mainly working with nursing, midwifery, and allied health professional schools. We We did work with some medical schools as well, particularly through the MEPI program. But certainly from primary care and public health perspective, the nurses and midwives and community health workers are probably a better investment, especially getting them into rural areas. Yeah. And so we also, help schools buy materials and equipment. And I think one of the huge lessons learned from this project was helping prevent student dropout. I remember back when I was working at the World Bank and talking with that. At that point, it was the only medical school in Mozambique. It was a public medical school, and being told they had a 30% dropout rate. And the dean said, every student that is admitted is qualified, and each dropout is a tragedy. But there seemed to be no attempts to prevent those dropouts. So we had some work to do to work with a large number of midwifery, nursing, and allied health professional schools in Nigeria. So we posited to look at the dropout rate and see if we could cost effectively prevent those dropouts. And did a lot of learning about, dropouts occur for 3 basic reasons. One is academic, one is financial, and one is social. Social being like, maybe your father decides he wants you at home rather than in school, or maybe your mother dies, or, maybe you develop depression, or, it's like a social medical issue. That's kind of a bucket for everything that's not financial or academic. And we found that there were relatively low-cost investments that could be put to prevent each type of dropout. And we found that we could prevent a dropout for about $500. So for the amount of money we invested, a dropout was prevented for about $500, which, given the amount of money it takes to train a nurse or midwife, is, I think, the best buy that there is in pre-service education. Because, we're often going around saying, we need to train, millions more health workers, we need to build hundreds more schools. Well, actually, if we solve this dropout problem, we'd frankly be halfway there, because we found most of the, in this work we did in Nigeria, most of the nursing and midwifery schools had about a 60% dropout rate. And many of these dropouts were financial dropouts in the last year. And you can't backfill a position. Once you're 6 months into a course, you can't backfill it if somebody drops out. And what business person would tolerate 60% defective widget rate? I mean, it just wouldn't be tolerated. But for some reason in academia, this is tolerated. It's really.
What were some of the interventions that you actually did?
So for the financial dropouts, we targeted final year people who were struggling, and people could apply for grants. And the criteria we looked at, family income, we looked at where they were from, the high school they had graduated from, whether or not it was rural, a stated intent to work in a rural area. So that was one of them, was a grant. Another was improving the academics. A number of schools, there was information on where people were failing the national licensing exam. Like, perhaps they were failing in the OBGYN section. We found that there was one school in the northern Muslim part of Nigeria where the OBGYN instructor was male, and so he could not teach at the perineum with the students. So they still got no teaching in that area. So we helped them hire a female professor who was then able to give them the education they needed, and they could then pass the exams. But really trying to, you can't make investments across the entire curriculum. You have to see, well, what's the weakest part of the curriculum that's causing people to fail their licensing exam? Because if you graduate from nursing school and fail your licensing exam, you're not a nurse. You cannot legally practice. And then for social, we found most schools didn't even take attendance. And so if Mary hadn't come in a week, no one even went to find out, well, why not? Is she sick? Did her mother die? Is she worried she's failing and is giving up? Well, what's the reason? So no one even looked into it. So even just following up on absenteeisms and just helping people can be very effective. We also did management reforms. We created a whole tool around managing health professional schools. Most deans, through no fault of their own, have no management experience. They were probably the best surgeon, or that type of thing. And health professional schools are very complicated institutions, and you would hear about a library collection being ruined for want of a $500 roof repair because we're physicians and no one's been assigned to do the roof repair. Or there's no budget for the roof repair, that type of thing. So really helping create a framework for how you manage a health professional school and what elements need to be managed, making sure that there's someone assigned to take care of every important component. Also, teacher support and improving pedagogy. Many people are teaching like they taught in the 40s and 50s, and trying to get things to be a little bit more didactic, a little more discussion-based, a little more practical, that sort of flows into curriculum and learning methods. Okay, I've discussed most of this with Nigeria. So yeah, this is the dropout work that we did. Let's see. So retention and productivity, I already discussed this. This is helping countries design systematically and evidence-based design retention programs. And this is that graphic I mentioned. So in the one here, you'll see there's a lot of counties in red. Those are counties where 50% or less of the paid-for posts are filled. So you have, a large number of posts open, whereas green means 80% or more of the established posts are filled, have an incumbent health worker. And so being able to see this graphically, the government of Uganda invested in training and hiring more health workers, increasing salaries, and you see that after about 4 years, the number of counties in red has been dramatically reduced. But you can show this to a parliamentarian and say, look, your county's in the red. Let's do something to make sure that more of your citizens get trained to be health workers and employed in your own community. And they were able to actually demonstrate that this led to more services. But we didn't go down to the level of improved health, because you can't. Our M&E budget would have been more than our implementation budget if we were to try to do that. Yeah.
How did you build capacity in the countries to continue to do this work?
So that we did data for decision-making training, also IRIS training, but a lot of this was in-service training, sort of workshops and things like that. I'm a big believer that we have to integrate that into pre-service education, that if you're going to most countries don't have programs for health information technology. We need to develop 1 or 2 year certificate programs for people who are going to support the health system from an IT perspective, that type of thing. Or in MPH programs, you need to build data for decision making in those MPH programs, or make sure every nurse and physician has maybe at least a 1-day module on working with data. Because to me, that is the real sustainability you're going to get, rather than sort of these fly-in training programs. We also did a lot of work on social service workers. This was a specific request from USAID that came out of the world of HIV/AIDS. Social workers are very under-recognized cadre. And unfortunately, there's this model of the master's level social worker, which is just not feasible in most developing countries. And so we help develop certificate level paraprofessionals who can do basic case management, finding children and other people at risk, referring them, that type of thing.
So they don't do the therapy, they just do the...
So case management, yeah. They can maybe do some basic therapy, but mainly it's just case management and coordinating, that type of, exactly. But there were some studies that showed that children who had case managers were much more likely, HIV-positive children with case managers were much more likely to get care, much more likely to be of a good weight, things like that, because someone was actually taking responsibility for the children. Also did a lot of work on supply chain workforce. So this is another, very under-recognized cadre. We spend billions of dollars, on medicines still. Billions of people don't have access to medicines. Medicines spoil on the shelves, incredible numbers of stockouts. And, if you go to a primary clinic in a rural area, the person in charge of stocking is probably a nurse who has clinical and administrative responsibilities. She's had no training at all in stocking or in ordering, and no time either, so no wonder there's a stockout problem. And so we helped professionalize them, help set up training programs, and helped also build career ladders for them as well. Okay. For gender issues, we worked, as I said, in sort of both aspects. One is looking at gender challenges within the health workforce, such as harassment of health workers or gender discrimination of health workers, but then also training health workers in gender sensitivity towards their patients as well. Okay. We worked a lot with faith-based organizations. USAID, I think, really can be commended for involving faith-based NGOs, which really have a great deal of sustainability in Africa, Asia, and Latin America, and helping them become more networked, become more organized. We supported this African Christian Health Associations platform, actually placed an HR expert with them. We found out that a lot of their members didn't have job descriptions, didn't have professional HR folks, they didn't even have contracts, actually quite a lot of lawsuits. We were able to show demonstrable improvements along a number of different areas in health workforce by actually providing them with professional HR advice. Let's see. This is the HRH Effort Index, which is a way to kind of score a country by how much they're investing in health workforce and compare across countries and create a little bit of friendly competition. And this is modeled after efforts in family planning and AIDS. There are effort indexes in these areas as well, where you can kind of, say to a Minister of Health, do you realize that you score worst on your continent investing in AIDS or investing in health workforce?
Is the ranking within their fellow countries?
Yeah. We usually do it by continent. Yeah.
That's within Africa, presumably?
Yeah. Mm-hmm. Yeah.
And the N is a score derived from the surveys or whatever's done in those areas?
Yeah, so there's a survey. It can either be self-administered or someone else can administer it for the country. Yeah. So sort of lessons learned. You really have to address the elephants in the rooms as ghost workers and this whole quality accessibility, tension that I see a lot of groups coming in and, talking about bringing in, sort of the state of the art in a lot of rural or developing communities, and it's just not sustainable. I think things should be fit for purpose. And Jehu Aputo, who I think many people in this room know, who's the former dean of Walter Sisulu Medical School, he likes to say the only difference between medical school and the job should be the paycheck. That, if someone's going to be practicing in an area where there's no x-ray or there's no lab or there's no electricity, part of their schooling needs to be in environments like that, because otherwise you're just setting up people to fail. If people are, are trained in these, sort of these elite ivory towers, and you send them to rural areas, that they're not going to be able to function properly. And actually, since we were the first main group in health to talk about ghost workers and do implementation around there and publish it, and since there's been a lot more talk about that, and so it's hard to give attribution, but I really have seen an increase in addressing this and feel good about that and making it something that can be talked about and that governments feel they can talk about.
On that topic, on that ghost worker, it's really interesting. A big intervention that has an impact. Are they now? Do they have something in place to continue to identify the ghost workers in their system, or was this sort of a snapshot of today? Here's how many you have.
My understanding is that they do, with the improved, because for them the discrepancy was between the local records and the central records, and so they now have a system where the two communicate better. That's my understanding. It's a good question, because the problem can just reappear.
So would the money get transferred? The money that's not paid to these people go to someone in the government, or what happened to the money?
With the ghost workers?
Yeah.
So often it was non-health workers who somehow managed to get on the payroll, or people who had multiple jobs and so were getting multiple paychecks, that type of thing, or people who were retired and getting a pension were still getting their salary and had neglected to mention it to anyone, things like that. A lot of different ways to be a ghost worker. Creating global public goods, such as IRIS, but also InterHealth has been very good about making all of its tools available, so that you don't have to reinvent the wheel. I'm also a huge fan of making curriculum available so that schools can adjust it to their needs, because I see so many schools using curriculum that are so outdated or spending money to update it, and I feel that probably for each continent we could create one and then share, and people could modify it as needed. I don't think there's a one size fit all, but having some place to start would be better than nothing.
That's applicable in the United States too.
Yeah.
We're looking at training people on care management, care coordination,
Yep.
and all those things, and
Yep.
every organization
Yep.
is reinventing the wheel.
Exactly.
But they don't
exactly.
trust each other. At least that's been my experience. Like hospitals don't agree on things. Like what extras? Do you have that kind of problem?
Well, no, it's if you have like a base that people can adjust, then every hospital could
Right.
adjust it differently. So yeah, I don't see that as the particular problem. Dropout prevention pays, I think, is one of our huge lessons learned, that I really think the single best buy in health worker education is dropout prevention, and that before we look at starting a lot of new schools, we need to prevent the dropout in existing schools, and that will go a long way. I firmly believe pre-service education is a route to sustainability. We have to stop all this in-service training. There's not a lot of evidence that affects behavior change. It's very expensive. People often are sent just for the per diem. You'll see people sent for the same course over and over again, or someone who doesn't see AIDS patients is sent to an AIDS training program, that type of thing. So pre-service education really is the way to go. Leadership is hard. How you build it in and how you keep it is very difficult. Leaders, people in prominent positions, are often acting, on a whole series of incentives, which may or may not be about actually improving people's health. And so getting high-level leadership and quality leadership is a huge challenge. And I do think part of the solution is building leadership into pre-service education, and part of the solution is getting communities to demand better health care and giving them tools. And luckily with the cell phone, often it's a lot easier now to report health workers not showing up or report stockouts, that type of thing. Because when you think of it, who really is affected by poor health care? It's poor communities, and you have to give them a way to report what they're experiencing and drive it from the communities. As I mentioned, parliamentarians are key. We need to engage them even more. We need to drive data use. If you don't use data, if you don't make decisions on data, there's no point in even collecting it. And all over the world, we're investing in collecting more data, even when the data that they currently have, the countries aren't using. So for me, the first step is get them to use the data they have, and then have them collect additional data. And then finally, the power of the private sector. Whether it was in pre-service education or delivery of healthcare. We really saw the private sector being extremely creative, being very nimble, and I think with universal health coverage, governments are increasingly interested in working with the private sector, and also in the current economic environment. I was in Nigeria about 4 months ago, and people were saying that when the government was flush with cash, with the high oil prices, they had no interest in the private sector. But now, with oil prices low and a bit of economic crisis, they're more willing to look at cost-effective ways of delivering care, and more willing to look at the private sector. And if you look at countries outside of Europe that have achieved universal health coverage, most of that has been done with the private sector, at least in part. Europe really is the only continent where they've achieved universal health coverage really through the public sector. So that's the formal part of the presentation, but I'd love to answer questions, or if people have challenges in their own programs, love to talk about
I
that.
have 32 myself questions, but
Great.
we'll share it around. Let me get it started. Hard to start, so many. Something you didn't talk a lot about, we thought about a lot in MEPI, I'd love your perspective on it, is the role of research, particularly in the academic sector.
Yeah.
So you have increasingly the NIH and others, the Wellcome Trust, and other international donors who are putting up research resources of various sorts to try to build into the expanding, certainly medical schools, but health science efforts. And the premise is a good one, that Flexner and others have said research ought to be part of the enterprise in health science training, and that it makes really good sense to marry that to the institutions. There are other arguments that is presents a bar, a barrier, an impediment, at the very least a slower down, where institutions are diverting resources into research training, research projects, and particularly in this day and age, health sciences education can be done on a computer. It can be done in a much more nimble way than tying it to the academic health center.
So
I'm
what-
more in that second camp, yeah,
Yes,
yeah.
but it's, to say a little more about what you observed, because it was a sleeping gorilla in MEPI. I mean, it was
Yeah.
always there, and
Yeah,
NIH has now been seeded what's left of MEPI,
yeah,
which worries me a lot, that it's gonna take it and
yeah,
let's build academic health centers
Yeah.
a la America
Yeah.
all over Africa.
yeah.
Which is, I don't believe what Africa
Yeah,
needs.
no, I I agree with you 100%. And actually, most of the schools that we worked with were schools who were aware that their goal was to train clinicians for poor communities. And that research in that context might be quality improvement, or, might be,
Health services.
yeah, more access research than basic science research, or, that type of thing. So, maybe one of the things we need to do is define, well, what is research? Because if you define research as quality improvement or service improvement, I'm all for it. But, if you define research as, stem cells and things like that, then, I would want there to be, clear walls between the education component and the research component. Because I think that the reason, especially in the US, we've outpriced ourselves out of training enough health workers to meet our needs is because of this entanglement between research and and training clinicians. So when I was in medical school at Hopkins, one of our teens told us that our tuition contribution was such a small part of the expense of training us that they were considering doing away with our tuition. We were like, please.
Yeah.
But in the end, I walked away with $200,000 in debt, and I'm still, I mortgaged it, and I'm paying $600 a month over the next 30 years. And there's no doubt that this debt, changes the practice behavior of health workers. So I would want to see a clear wall between the research aspect of and education of health workers.
Hey, curious about the how you were received in general. I'm assuming that the countries, on one hand, have a desire to improve health status, but you're coming in from the outside. Were you received more welcoming in some countries than others? What do you think some of the key variables are?
I mean, it really depends on the country, and all of our interventions were designed with the ministries of health and ministries of education. But that being said, when you come in with money from USAID, people often say yes to things they're not particularly interested in. If they can tell you're interested in something and that you're not going to invest in what they're interested in, they'll just say yes because they want the funding to flow. So it really does depend. I mean, the country that's most likely to stand up for what it wants is Ethiopia. That's because they have incredibly strong health workforce leadership. They have a strong plan. They've been very successful. And they'll push back, but they'll push back, with good ideas, and not just pushing back into sort of these strange things or pushing back into someone's pet project. But yeah, it varies so much by country. Yeah.
I was interested in your vertical and horizontal discussion. I know that I've heard that at PEPFAR, they've been training HIV nurse practitioners. They have these people called HIV nurse practitioners.
Yeah.
And they're now trying to re-educate them or using them in primary care. Is that happening globally, or is that a trend to move away from the vertical to the horizontal?
I hope so. I'm not familiar with that specific program within PEPFAR, but
In South Africa.
yeah, but I stand by what I say. I mean, you have to be a nurse practitioner before you can be an HIV/AIDS nurse practitioner.
Which
Yeah,
would be true here, but may not be true there.
Yeah, no, it's true pretty much everywhere. I mean, the only thing that's there's some disease-specific things like an HIV/AIDS counselor or that type of thing, or at the community health worker level, you have a TB community health worker or malaria health worker where they're only trained in that one thing. But once you're at the nurse level, there has to be otherwise they're not a nurse. It wouldn't fit the definition of a nurse.
Well, no, these are nurse practitioners who are nurses who are specializing in HIV.
Yeah, but what I'm saying is they're nurses first. Yeah.
Just to pursue Joyce's question for a moment, and your thoughts on it. When MEPI, when PEPFAR evolved to fund MEPI and NEPI, they were moving away from a very vertical interpretation of HIV into, you've got to train workers who are generally competent that will help with HIV, but will help with everything else.
Yeah.
That was arguably the Gooseby view. it seems to
with
me that
Berks,
move
it's,
back.
yeah, it's switching back, yeah.
And
Yeah.
the second thing that's happened is MEPI and NEPI have not been refunded effectively.
Yeah.
What is your reading? Has the day of health workforce in terms of U.S. investment anyway passed?
You know, we'll see. You know, I was serious about what my husband said about Trump. You know, and also the age wave is going to be hitting Europe, and actually, we were talking about that last week. The age wave will be hitting Europe and North America very hard, and I think that we'll be recruiting many more health workers from Africa and Asia and Latin America to meet our needs of aging Americans, and also because
Which will make, you're saying, make us more interested in
I think
improving the
so,
training
but
in our
also
power clubs?
I think that there'll be a number of tensions. One is because of the expense of taking care of a large number of aging people, we might not have as much money for global health work. Because the interesting thing is, you know, the money that's helped address the Syrian refugees has been European global health funds. And so because that money went to help the Syrian refugees, UNFDP has had its budget cut by 40%, UNAIDS has had its budget cut by 40%. So if you think European global health funds are sensitive to just one refugee crisis, I mean, imagine what's going to happen when there's the next crisis, or when Europe has to deal with its, you know, its aging situation. So.
Our best days may be behind us.
So we'll see, and you know, I am now focusing on the private sector, and looking for private funding of health workforce work rather than public funding.
So Kate, on that topic, one of the, it seems from MEPI learnings as well that, you know, quality, et cetera, but even engaging the private sector, the regulatory environment becomes so important, even if it's to ship it back out,
Yeah.
you know, for whatever
Yeah.
reason, but
Yeah.
obviously the primary reason being even in country.
Yeah.
Do you see this being an investment of the future because we necessarily need it?
Well, you mean investing in the private
The
sector?
regulatory environment. I think that's where
Yeah.
we need a strong regulatory investment to enable and empower that private sector
Yeah.
to produce the right kind of graduates.
So the challenge is both in the regulation that's on the books and also the implementation. You know, in many countries, there's really no regulation whatsoever, and so the private sector and the public sector, you know, get away with murder. But also, I've been in countries where the government's been hostile to the private sector and really purposely used regulation to either make private sector illegal, you know, like you know, private medical schools, or you just make it very difficult for them. We had helped support a Ghanaian midwifery program to get started, and one of the burdens that the regulators put on them was to have a global partner for a midwifery school. It's just ridiculous. There's no reason whatsoever why that would be necessary. And certainly when they start a public midwifery school in Ghana, they don't require it to have a global partner, nor should they. So yeah, there's a lot to be done. And also, you know, how to make regulation affordable. Once more, I think this is where some of the global public goods come in. We had put in a proposal, it wasn't funded, to work with SIDMEF. SIDMEF is I'm not Francophone, so I sort of come lately into sort of the Francophone world. SIDMEF is the global institution that regulates all Francophone medical schools. So this is medical schools in France, Canada, Romania, Vietnam, West Africa, and a couple of other sort of historical relationships. East African Federation is now doing regional regulation of medical schools, and I'm kind of of two minds about that, because you know, every country is different. Every country has different resources, and so the poorer countries might suffer because they're having to get to a standard that's not relevant to them. But if this regional regulation somehow makes regulation easier or makes it less expensive, in that case I would be supportive of it. Yeah.
I want to go back on the ghost worker. I'm sorry. There was this question of diligence. Again, for reflections, I work, I think you know, with C Global Health, which is a 4 or 5 year effort now to send medical faculty abroad, the U.S. folks, for a year at a time, working with Peace Corps. When you go to debriefing, is a variety of stories, and it's both medicine and nursing. We have both in there, and the stories are strikingly similar about lack of diligence to duty on the part of their counterparts.
Yeah.
Now, it's not uniform, it's not everybody everywhere, but just the professors don't show up.
Yep.
You have people assemble a class, nobody's there, or the professor comes unprepared.
Yep.
Everybody has day jobs or night jobs or other jobs. And it's partly a characteristic of a stretched-thin system where people are kind of making do. But at least listening to them, and I've heard enough primary, seen enough primary, there's not the same sense of attention to your job as I'm used to, or we're used to. Now, that's very prejudicial, poor evidence, big comment. But the existence of ghost workers and
Yeah.
all these other things that are systemic seem to feed into that same
Yeah.
syndrome. Do you observe that syndrome? Is that real? And others who work?
Yeah, the phenomenon of dual practice is very real, and the World Bank has studied that extensively. And there have been some missed opportunities. About, I think, 10 years ago, Dominican Republic legalized dual practice. It had been illegal, and they were trying to lock people up.
If you work for the government, you can't.
Exactly. And they decided to legalize it, but there was a real missed opportunity because on legalizing it, they should have asked the health workers for something in return. Basically saying, well, we will legalize it, but in return, you will have to, fingerprint scan in and out, or something like that to really put teeth behind it. Because what happened is they legalized dual practice, but then there was no rigor in anything, and so people just, spend even less time at the hospital than they were before. And there's actually documentations of maternal deaths because there was no obstetrician, at the hospital, to perform a C-section, that type of thing. So, every labor market's different, and when there are only 4 urologists in the public health system in Uganda, they can come and go as they please. You're not going to fire them because there's no one else to hire. But in other job markets, perhaps it's a nurse who's not showing up, and there are other nurses you could hire. So perhaps there does need to be a little bit more accountability, and you need to fire people who aren't, aren't doing their duty, or perhaps redefine what the duties are. Perhaps it's no longer realistic in certain areas to expect an attending physician to be at the hospital from 9 to 5. Perhaps you negotiate something. We'll be here from 9 to 12, but you have to be here, and we'll hold you accountable. That type of thing. Yeah.
So smart compromises.
Yep. Yeah.
It's a big problem, I think, and I know that it's
It's
easier for Americans
huge.
to say,
Yeah.
well, it's not the way we do it, but.
Or just, I think one thing that happens in many hospitals is all the physicians will be there at a certain time, and then there's no one there at other times. But to
Yeah.
say, okay, let's make it so there's at least one physician in the hospital at all times, and just try to negotiate that and work that out, and so the burden's kind of spread around so that there is someone there at midnight, or there's someone on call at midnight.
Please, the last question.
Well, I'm less familiar with other countries besides the U.S., and so I'm trying to draw what your list is in the U.S. And I'm really curious about if you see parliamentarians or the equivalent of Congress.
Oh,
here
absolutely.
being
Yes,
how would you-
absolutely.
Yeah, the legislators. How would you?
Yeah. Well, I was just talking to Fitz. I'm on the board of the National Physicians Alliance, and am active both nationally and also in Virginia, where I live. And one thing that I have spoken to my legislatures about is establishing a business innovation cluster in Virginia around senior service businesses. I want Virginia to be a leader. And business innovation clusters, the whole concept is like you have Silicon Valley, which is a cluster of tech businesses. You have the fashion district, or you have Wall Street, which is a cluster of financial businesses. And that if you give incentives for national, regional aging companies to locate in Northern Virginia, you will become the leader in that area. So I think there also one thing I'm trying to get done in Virginia is for them to open more health professional schools, also open more high schools, health sciences high schools, particularly in minority areas, to get that pipeline for African Americans and Latinos to become health workers. We're training fewer African American men to be physicians than we were in the 70s. It's really quite tragic. So I think most of these are probably not dropout. I'm not the ghost workers. So I tell you, if I show up 5 minutes late at my shift, the pediatrician is there is going to be calling me. Let's see what else. We certainly need to improve, expand pre-service education in the U.S., make it more accessible to minorities. I'm very concerned about what I call credential creep. in the U.S. how basically for almost every cadre you now need to have a doctoral level, which I think is just ridiculous. I think it's unnecessary. It increases the years of training, increases the debt, the lost opportunity of income, makes people more likely to practice in metropolitan areas, more likely to subspecialize, and so it's like the opposite of access.
And we do that in a lot of fields. I mean,
Yeah,
we do
yeah.
with pharmacists and
Yeah,
physical therapists.
yeah. And interestingly, it's only in the health sector. I've looked at like engineers and lawyers, and there's no, and you don't see it happening.
The same tendencies there. I've actually looked at some few professions, and I think the idea is, of course, to get more. Well, the physical therapists won't be interviewed; they just
Yeah.
want more control and be loose from the doctors.
Yeah, yeah.
But it's often an income thing.
Yeah.
They want more control.
Yeah.
They want to limit the supply.
Yeah. See, it's not about access, or
No.
they'll say it's about. Once again, this is the quality.
They say it
This is the
is,
quality access
right.
thing. You know, when you ask a nurse about why they think every nurse should be a bachelor's, they say, well, there's all this, evidence of better quality care in hospitals. But
Most nurses aren't there.
Exactly. Or most health, doesn't occur in the hospital. So, and also when you look at the majority of Latino and African American nurses come up through the certificate programs, not through the bachelor's programs, and so you're cutting those communities off and really not considering access. Yeah.
Well, great for principals and
Why don't you see if anybody on the phone has a question?
yeah, anybody on the phone with a question? All right.
No, but thank you for the great presentation.
Oh, thank you.
Good. It was terrific, Kate. We could stay another hour picking the bones, but it's good. A lot to think about.